Good afternoon, everyone. I'm Dr. John Shrigley, the expert lead for pathology at the Canadian Partnership Against Cancer. On behalf of Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists, I would like to welcome you to today's CAP checklist education session on thymoma and mesothelioma. Before I introduce our speakers and we get underway formally, I'd like to take care of a few housekeeping items. Firstly, the session is being recorded and will be made available to all participants via email links once the recording becomes available. Both the live and the recorded presentations are eligible for CME credits. The information for obtaining credits was provided in the notice of the session that was previously distributed. Please note that the CME certificates for each of these sessions will only be issued for 1 month from the presentation date. Please refer to the session notice for the exact deadline date. Please note that everyone's line has been automatically muted for today's presentation. We have a large number of participants and are unable to troubleshoot WebEx issues as part of this call. If you are having difficulties with the WebEx, please call the WebEx support line at 1-866-229-3239. We encourage you to submit questions at any time during the presentation using the chat feature. The documentation previously distributed provides instructions on how to use this chat feature. During the question and answer portion of the presentation, in order to avoid question collisions, a CCO staff member will pose the submitted questions on your behalf as long as time permits and in the order that they appear. In the chat window, please include the following information: your institution's name, the name of the individual posing the question, and finally your question. It is now my pleasure to introduce Dr. Andrew Churg and David Hwang for today's presentation. Dr. Churg is a professor of pathology at the University of British Columbia and a pathologist at Vancouver General Hospital. He is the author of some 400 journal articles, book chapters, and books on all aspects of lung and pleural disease, including Thurlbeck's Pathology of the Lung, the Atlas of Interstitial Lung Pathology, and the 4-series AFIP fascicle, Tumors of the Serous Membranes. Andrew is also taking the charge in mesothelioma for the new WHO Thoracic Blue Book and is also chairing the International Collaboration on Cancer Reporting Dataset Group that's producing a new international dataset for mesothelioma. Dr. David Hwang is a pulmonary pathologist at University Health Network and associate professor in the Department of Lab Medicine and Pathobiology at University of Toronto. He's a graduate of the MD PhD program at University of Toronto, completed his residency at U of T, and trained in pulmonary pathology both at Toronto General and the University of Pittsburgh Medical Center. He has active research interests in both neoplastic and non-neoplastic lung disease. Dr. Hwang currently serves on various lung-related working groups for Cancer Care Ontario and is also the chair of the lung expert panel for the Canadian Partnership Against Cancer. So without any further ado, I'm going to introduce Dr. Churg and Dr. Hwang to you today to give today's thymoma mesothelioma presentation. And I think Dr. Churg is going to be leading off. Andy?
Yes. John, can you hear me?
Yep.
Good. Okay. Good morning or afternoon, everyone. We're going to do this a little bit differently because very few hospitals have resections of mesothelioma. So we thought we would actually talk first about the diagnosis of mesothelioma purely as a diagnostic issue, and then Dr. Hwang will talk about staging. And I don't have any disclosures to reveal. So if we start with the basics of mesothelioma, you'd like to know that a tumor you think is a mesothelioma surrounds either the lung or, if it's peritoneal, the peritoneal organs. I used to think that was crucial, but it's not, because the morphology in most cases is pretty distinctive. But here's an example of a mesothelioma surrounding the lung, growing down the fissures. That's a perfectly good example of a mesothelioma. One point which sort of gets lost is that mesotheliomas do metastasize, and on the right is an example of a mesothelioma at autopsy that has metastasized. But the important thing to remember is that it's fairly uncommon for mesotheliomas to metastasize at the time of presentation. So statistically, if you're dealing with a thoracic tumor and it presents with metastatic disease, the odds are overwhelming that that's a lung cancer and not a mesothelioma.
So, you know that paper you have? Call the toll-free, 1-855, and then that's your access code. I'm doing my phone.
There's also a certain amount of
put it on speaker, maybe.
Discrepancy in the literature about what mesothelioma should look like when they're early, and what they look like when they're early is shown in this example. Peritoneal mesothelioma, they simply look like multiple tumor nodules. There's nothing specific about the gross appearance. You have to have the micro. Now, what about the classification of mesothelioma? This is the basic classification that's in the Series 4 fascicle, the WHO 2004, and is going to be in the WHO 2015. And that is, divide them into epithelial, sarcomatous, and mixed epithelial and sarcomatous, which is also called biphasic. If you look in the literature, you can find various names, and I've listed some of them here, for different types of epithelial mesothelioma. And my advice is, except for the pleomorphic ones, and I'll come back to that, don't try and use these names. Why not? Well, for one thing, there's no reproducibility among pathologists with these names. Even more of a problem is mixtures are common. Here are 4 morphologic examples of an epithelial mesothelioma, completely different looking. The secret, of course, these are all from the same case. And you can see the sort of problems you get into once you start saying, well, how should I subclassify this? The fact of the matter is subclassification at this point for plural mesotheliomas certainly is of no value whatsoever. But if you stick to epithelial sarcomatous and mixed epithelial and sarcomatous, you get a good correlation among pathologists, and there's a good correlation with survival, as we'll see at the end. Now, there's some basics of mesothelioma that are useful to think about. Mesotheliomas tend to have, when they're epithelial, very monotonous cells. That is, for a tumor that's very aggressive, the cells really tend to look the same, and they often are cuboidal or flat. Columnar cells should make you think you're dealing with a carcinoma. So we have a mesothelioma on the left and a carcinoma of the colon on the right. With the carcinoma, the cells are columnar and also, as you notice, much more pleomorphic. Epithelial mesotheliomas tend to be deceptively bland looking. Epithelial mesotheliomas also grow in very simple patterns. They make simple glands, and if they branch, as here, they tend to branch outwards at right angles. Most carcinomas don't do this. Most adenocarcinomas have a tendency to branch inwards and make gland within gland patterns, such as shown here. And for whatever reason, epithelial mesotheliomas do not ever, in my experience, make gland within gland patterns. Here are some examples of epithelial mesotheliomas. I show them to you, and again, I want to emphasize, there's no point in trying to put names on these. These are simply epithelial mesotheliomas. Here's one. Here's another one. This is extremely common, this pattern of sheets of cells. And again, notice the monotony of the cells. For a malignant tumor, it is deceptively bland. Here's the so-called tubulopapillary pattern with papillae with a single layer of cuboidal cells covering the papillae and simple tubules. This is the so-called deciduoid pattern, and again, when I give you these names, that's for us. Don't put it on a diagnosis line. This is simply another form of epithelial mesothelioma. Deciduoid mesotheliomas were first reported in the peritoneal cavity in women. Initially thought, in fact, to be deciduosis, but now it's clear that they occur in the pleural cavity and they occur in men. In mesotheliomas, epithelial mesotheliomas, it is common to find lumens, intracellular lumens such as these. These do not stain with digested PAS, and although nobody wants to use PAS anymore because it's not in vogue, that's sometimes useful because most, not all, but most adenocarcinomas will stain with this appearance. Sometimes the vacuolization gets quite dramatic, as in here, and you have something that looks kind of like an adenomatoid tumor. Again, this is just a variant of epithelial mesothelioma, and you really don't want to make any comments about adenomatoid. Just diagnose it as an epithelial mesothelioma.
Does anyone mind if
So here's another summary slide just to show you the numerous patterns that you can see
Do you mind that?
in epithelial mesothelioma. Let me turn now to immunohistochemistry. This is a list, and it's actually not quite comprehensive, of some of the markers that have been proposed to separate mesotheliomas from carcinomas. And if you think about it, this is ridiculous. There's no other tumor for which anybody goes to this extent to try and make this distinction. And the truth of the matter is, in 95% plus mesothelioma cases, you can use a fairly simple panel of immunohistochemical stains, and they're going to work. Sometimes it's true they don't, but 95% of the time they do. The important thing to remember, however, is there is no magic bullet. And this is a nice example compiled by Tom Colby, just to make the point that there is always some overlap for virtually all of these stains between mesotheliomas and carcinomas.
Line muted.
It depends on the specific antigen. It depends on how it's set up in your laboratory. But if you take, for example, BER-EP4, and I see a lot of consults where people use this, and they say, well, it looks like a mesothelioma, but it's staining for BER-EP4. The answer is yes. There is an overlap with that particular stain. That's a stain I wouldn't pick. Even something as simple or good as MOC31, which mostly works, has a certain amount of overlap. So bear this in mind. And the solution to this, in general, is to pick a panel. I'll show you the sorts of things I use for a panel in a minute, but the important thing to remember is you have to pick what works in your laboratory. You can't really do these blind because your lab, the way your antibody is set up, may give you funny results. So here's a nice mesothelioma. Again, I showed you this before. Typical epithelial mesothelioma. This one's positive for CK5-6. It's positive for calretinin. It's negative for CEA. That's good. Stop there. You've got the tumor. You've got the expected staining. But here's aberrant staining. Another perfectly good mesothelioma is positive for calretinin, WT1, D240, and CK5-6. Now, those are all, in this context, good mesothelial markers. But notice MOC31 is also quite diffusely positive. In my experience with consults, this is very common. I don't know if it's because people use MOC31 at too high a concentration of the primary antibody, or it's real staining. But in this situation, I follow Schnitt's maneuver. And Schnitt's maneuver is very simple. When you get this and your MOC31 is giving you problems, accidentally drop the slide on the floor and roll your chair over it. Because this is clearly a mesothelioma, and there's no point in worrying about the MOC31. There is a newer antibody which sometimes helps, and that's Claudin-4, which is a very broad spectrum marker of carcinomas. So here's another mesothelioma. Again, notice how bland it looks. Positive calretinin, D240, MOC31, BER-EP4. Well, what are you going to do with this? You've got two mesothelial markers positive, two putative carcinoma markers positive, and you have a conundrum. In this circumstance, I find Claudin-4 is often useful, and it's, as you see here, it's negative. So which antibodies should you use? If you're unsure of whether you're dealing with a mesothelioma or carcinoma, my suggestion is start with two mesothelioma markers and two carcinoma markers. It's very important to modify your markers to account for the likely primary site. In the peritoneal cavity, WT1 is not a good choice because it's going to stain some gynecologic tumors. As I said, and I'm going to reemphasize, you need to know how these markers behave in your lab. If you don't do that, you may find very funny results. And of course, the more markers you use, the more anomalous results you can expect. Being an old-fashioned pathologist, I start with the H&E and make a judgment about where I think I'm going. The other point is most sarcomatous mesotheliomas only stain with pankeratin. People send me cases and say, well, this looks like it ought to be a sarcomatous meso, but it does not stain with calretinin or CK5-6, and the answer is that's just fine. So for sarcomatous mesotheliomas, the rules are different. What do we use? I pick from this panel on the left, calretinin, CK5-6, WT1, D240. Calretinin should be positive in 95% of epithelial mesotheliomas. If you have something you think is an epithelial mesothelioma that's calretinin negative, it's time to worry. On the right, some potential carcinoma markers, and again, you've got to decide what you're going to use depending on the site. What about high-grade tumors? Occasionally you get high-grade looking epithelial mesotheliomas, and the important thing to remember is statistically a high-grade epithelial tumor in the pleura is vastly more likely to be a carcinoma of the lung than it is a mesothelioma. So if you have a tumor like this, which turns out to be a pleomorphic epithelial mesothelioma, you want the staining to work properly. This one's calretinin and WT1 positive, MOC31 negative. If all you have is pankeratin and nothing else is positive, then you may simply not be able to sort out an epithelial mesothelioma from a carcinoma. So to summarize, don't use the various subtype names that people have been proposing for epithelial mesothelioma. They aren't any use to clinicians. They aren't reproducible. And don't get hung up on the immunochemistry. If the tumor looks like a mesothelioma and most everything fits, just call it, even if you've got one anomalous stain. Let's look now at sarcomatous mesotheliomas. Sarcomatous mesotheliomas can be fairly monotonous, as this one, but they can also be quite pleomorphic, as this one, and that is not unusual. So the sarcomatous tumors are different from the epithelial ones. The epithelial ones tend to be monotonous. The sarcomatous ones often are quite high grade. As I said before, for sarcomatous mesos, pankeratin stains most all of them, but often is the only thing that stains. Now, this is data from Victor Rogley's lab showing that in a very large series of sarcomatous mesotheliomas, 93% were pankeratin positive. The particular example I'm showing you here happens to also be calretinin and WT1 positive, but that's uncommon. Most of the time, the only thing that stains is pankeratin. So you need some clinical information. If you've got tumor in the pleura radiologically or by surgical inspection, and there's no evidence of a primary, and it's a sarcomatous tumor that's pankeratin positive, then you're probably dealing with a sarcomatous mesothelioma. Sarcomatous mesotheliomas can show heterologous differentiation. Here's one that looks like chondrosarcoma, and there's a useful trick. The heterologous elements, whether they're chondrosarcoma or osteosarcoma, usually are pankeratin positive, as is this one. I think I'll switch this and see if it works better with a full screen. Here is so-called lymphohistiocytoid mesothelioma. And this, of course, at first glance looks like it's either Hodgkin's disease or a diffuse large B-cell lymphoma. And that's the trick with this type of mesothelioma. But when you put the markers on, here's a pankeratin, in fact, it marks like a mesothelioma. Some people say these should actually be classified as epithelial mesotheliomas. Here is a mixed epithelial and sarcomatous mesothelioma, and the important point to remember is you can have any mixture whatsoever. So this one has simple glands with outward branches. Notice again cuboidal cells that are very monotonous. In the sarcomatous component, this looks like osteosarcoma, and there's even a little bit of metaplastic squamous tumor, which is unusual but occurs occasionally in mesotheliomas. Let's talk now, last thing, about desmoplastic mesotheliomas, because these are particularly difficult variants of sarcomatous mesothelioma. They can be very hard to diagnose. There are problems with sampling errors, and one has to be suspicious but also careful. These are the rules that we set out a number of years ago for desmoplastic mesothelioma. The bulk of the lesion is paucicellular and shows a storoform or so-called patternless pattern, which is really a short storoform. But it has to have something else because this by itself is not enough. And the most useful thing is stromal invasion, which is generally fat invasion. Things that are not as good are bland necrosis. It's pretty good, but I'm always a little cautious if all I see is bland necrosis, or overtly sarcomatous foci, or nodular stromal expansions, or occasionally these tumors present with distant metastases. Here's a desmoplastic mesothelioma at low power. And at first glance, it looks completely bland, paucicellular, very fibrotic. This is the short storoform or patternless pattern of Stout. And typically, you see this kind of ropey collagen with cells and slits. This is typical of desmoplastic mesotheliomas, but unfortunately, it's not specific. You can see it in benign organizing pleuritis sometimes. The trick in this case is to look at the fat. Something's going on in the fat. When you're dealing with mesothelial proliferations and there's something in the fat, that's the time to be very careful. And if we look at higher power, it's hard to be sure, but you get the impression that there are spindle cells in that fat. And the way to figure that out is to use a pan-keratin stain. Desmoplastic mesotheliomas are always strongly and diffusely pan-keratin positive, and here you've got keratin-positive cells coursing through the fat. A good rule of thumb with mesothelial proliferations is if you've got mesothelial cells, either epithelial or spindled, in the fat, that's malignant. I have yet to see a benign mesothelial proliferation with cells in the chest wall fat. Here's another example of a desmoplastic meso invading fat. Again, on the H&E, you get the impression there are spindle cells growing between the fat cells. Here it is at higher power. And you can see clearly now spindle cells, and they just push the fat cells apart. And here's the pan-keratin. So same rule applies, pan-keratin positive cells in the fat. This is a desmoplastic meso. Invasion of fat is a very reliable sign of malignancy.
But how does it come to?
Be a little careful, though, with pan-keratin. It's important to remember that any kind of active mesothelial proliferation is pan-keratin positive. Benign ones are pan-keratin positive. Malignant ones are pan-keratin positive. Keratin staining doesn't make the proliferation malignant, but keratin staining tells you where are the mesothelial cells. And if they're in the fat, then they are malignant. Here's an example of how pan-keratin helps you. Here's an organizing empyema. And the fat looks like something's going on. Here it is at higher power. And this sort of thing you look at and say, well, are those spindle cells? I'm not sure. And I'm not sure I could pick them out here. But here's a pan-keratin stain. There's absolutely nothing pan-keratin positive in the fat. The pan-keratin positive cells stop very sharply, and that's typical of organizing pleuritis. So again, pan-keratin is very helpful because it tells you where the proliferating mesothelial cells are. But I want to reemphasize, pan-keratin positivity does not make something malignant. It only tells you where the cells are. Okay. I seem to have a little interference. All right. Sarcomatous foci, in my opinion, are not a very good criteria. Here is a desmoplastic meso with nice ropey collagen. Here's a sarcomatous focus. These are very subjective, and I don't use this very much. Bland necrosis is better, but again, I'm always cautious with bland necrosis. And why it's called bland necrosis is here's a necrotic tumor. There's no reaction. the background is the short storiform pattern that fits for desmoplastic mesothelioma. It's suddenly necrotic in this fashion, no reaction. That's at least strongly suspicious. Depending on what the situation is, if I'm told there's nodular pleural thickening, I probably would call this a desmoplastic mesothelioma. But I'm cautious with bland necrosis. It's not quite as good as invasion of fat. Here's bland necrosis in fat. And if notice at the upper right-hand corner, there are nuclei, but all of a sudden they're lost. And that's a desmoplastic meso with bland necrosis where it's invading fat. Another criterion which is helpful, and again used cautiously, are nodular stromal expansions. Here's an unusual desmoplastic meso that is thin. It's on the visceral pleural surface. And if you look closely, there are these vague nodules.
Dr. Schreck?
And yes.
Sorry to interrupt. We're not able to see the images, actually. Are you sharing your screen?
Yes.
Sorry, it's not coming up on our screen. You can
All right. Let's see where we are here. All right, I'm going to go back to share.
Yes.
How's that?
Yeah, we can
okay.
see now.
All right. So here is this vague nodule, several vague nodules. This is a sign, again, of malignancy. It's a pretty good sign. Is it perfect? Not as good as invasion of the fat, but you have to put this into the context of your case. You don't see these kind of nodules, in my experience, in organizing pleuritis. Okay, I'm going to switch this back to full screen. Everybody can see?
Yeah.
Yeah? Okay. Something that is sometimes useful with desmoplastic mesos, and for that matter epithelial mesos, is to look for deletion of P16 by FISH. This was first reported in tissue by Sonia Dasik at Pittsburgh. And if you can show homozygous deletion, that is a 100% accurate sign of malignancy. Here is a benign reaction in which we've got the green chromosome 9 centromere signal and the red P16 signal. And you should normally see two of these in every cell, but of course don't forget it's a section, so there are truncation artifacts. Here's a mesothelioma with the green signals for chromosome 9, but no red signals. So this is 100% deleted, and that's a sign of malignancy. And here's an example of how that helps. Here's a thick pleura, and here's a vague nodule. Very hard to be sure if it really is a nodule or not, but I was suspicious that that was a desmoplastic mesothelioma. The H&E at higher power doesn't help you, but if you look at the P16 FISH, well, there's one red signal there, but most of these cells have lost their red signal. So this is a P16 FISH deleted proliferation. That is a desmoplastic meso. Now, P16 immunochemistry does not, interestingly enough, give you the same answer. It does not substitute for P16 FISH. So, some comments in summary about sarcomatous mesotheliomas. They are often much simpler in the sense you don't get mixtures. They frequently are quite atypical and quite pleomorphic, and that's okay in a sarcomatous mesotheliomas. Desmoplastic mesos are a problem. You have to be suspicious. Sometimes you simply are not going to get a good sample. And if you have a large specimen, let's say a decortication, and you're suspicious, you may have to put the whole thing through. It's a nuisance, but sometimes only a few areas will show diagnostic features. Again, just to reemphasize, most sarcomatous mesotheliomas only show pankeratin staining when you do immunochemistry. The fact that calretinin and WT1 and D240 are negative is not a problem in a sarcomatous meso. Last thing, survival, and why I said that is really useful to simply stick to epithelial, biphasic, or mixed and desmoplastic sarcomatous mesos. This is data from the French mesothelioma panel. And you can see that epithelial does better than the mixed, and those do better than the sarcomatous and desmoplastic. None of this is good. If you look at the median survivals, it runs from 14 months for the epithelial down to 4 to 5 months for the sarcomatous. So it's terrible. But there is a reproducible difference in survival. For peritoneal mesos, it's important to know that the rules are a little different. For peritoneal mesos treated with surgical debulking and hot intraperitoneal chemotherapy, things have changed. And this is data from Sugar-Baker showing survival up to 5 years for women treated in this fashion around 70%, for men around 40%. So peritoneal mesos are a whole different kettle of fish. And I always make a comment in a report on any peritoneal meso that the survival is now recognized to be much better and that this patient needs debulking and hot intraperitoneal chemotherapy, because a lot of oncologists and physicians don't know about this, and they simply say to the patient, you have an incurable malignancy. So I always make a comment about this when I'm diagnosing peritoneal mesos. So just to sum up and reiterate a few points, epithelial mesotheliomas tend to be remarkably bland. The cells usually look quite monotonous, and that's perfectly okay. Sarcomatous mesotheliomas, on the other hand, frequently are quite high grade, and that's okay as well. Tailor your immunochemistry to the site morphology and your differential. And think about where this tumor is. Are you in the pleural cavity, the peritoneal cavity, a man, a woman? Because that may affect your choice of immunochemistry. Sarcomatous mesotheliomas, as I just said, are only usually pan-keratin positive. Can you have a pan-keratin negative sarcomatous mesothelioma? Occasionally, but that's typically in very small biopsies. If you've got a good-sized sample and the tumor is pan-keratin negative, I would start to think about some other type of sarcoma. Don't get hung up on aberrant immunostains. If you've got a tumor that looks like a mesothelioma and mostly stains like a mesothelioma, don't worry if you've got one anomalous stain. It's common and it doesn't change anything. And lastly, always look very carefully with mesothelial proliferations if there's something going on in the fat, because that's often the best place to find invasion. Okay, I think that's the end for me. And I'm going to stop sharing.
Okay. Yeah. There is one question from a participant.
Mm-hmm.
So the question is, in biopsies with mesothelial proliferation and no invasion, can I make a definite diagnosis of malignant mesothelioma based on P16 homozygous deletion?
The answer is you can, yes. This is actually a complicated question you've asked. We like to see invasion for a diagnosis of mesothelioma, but sometimes you get a biopsy, particularly from a VATS biopsy, that's a good-sized chunk of tissue, let's say 5 millimeters across, and it's all tumor. And I don't have a problem with that. I can't see invasion because every bit of it is tumor, but we're all good at picking out a proliferation of something and saying there's just too many malignant cells here. This has to be tumor. Could you use P16 FISH in that circumstance? Yes, you can, and that's perfectly good. And in fact, I do use it in the circumstance where I've got too few cells or a funny pattern. So yes, it's a good approach.
Great. Those are all the questions that we have.
Okay, I need to relinquish control here, or are you back?
Yeah, I think Dr. Hwang. Dr. Hwang, are you okay?
Yep.
Yeah. Okay. Perfect.
Okay, so in the next 25 minutes or 30 minutes or so, we're going to be working our way through the CAP protocols for mesothelioma, building on what Dr. Churg has just said, and spend some time also looking at the protocols for Thymoma and Thymic carcinoma. These are my disclosures. Okay, so the CAP mesothelioma protocol, the current version was initially posted in 2011. There may be a number of centers, and many centers may not actually use this all that much because it's meant to be used with resection specimens rather than the smaller biopsies. So as with most protocols, it starts with a section on specimen information, so the specimen type, the procedure that's been done, specimen integrity, whether it's intact or disrupted, and whether it's from the right or left sides. One thing to note with the procedure, pleural decortication and pleurectomy seem to mean different things to different people, and if you ask two surgeons, even within the same thoracic surgery group, you may get different answers. So when in doubt, it's best just to ask the surgeon what he wants this to be labeled as. Pleural decortications and pleurectomies are probably more commonly done. Extrapleural pneumonectomies are not done in many centers across Canada, but around the world there may be more. And this is just one example of an extrapleural pneumonectomy from the right lung. You can see upper, middle, and lower lobes with tumor in the fissures. And this comes with a resection of the hemidiaphragm at the bottom here, as well as parietal pleura all around, mediastinal tissue, and usually a piece of the pericardium as well. In terms of tumor information that the protocol requires, tumor site, so the pleural surfaces that are affected, be it parietal, visceral, diaphragmatic, or others. Tumor size and tumor focality. Most mesotheliomas are diffuse. Very occasionally they may be localized and have a somewhat better prognosis, but for the most part they tend to be diffuse, in which case this tumor size field is not really used because it's really intended only for localized tumors. Histologic types of mesotheliomas, Dr. Churg's done an excellent job reviewing these. The CAP protocol does separate desmoplastic mesothelioma out from the sarcomatoid types, but more or less follows the WHO classification, requiring 10% of each component for biphasic type diagnosis and greater than 50% desmoplastic areas for the desmoplastic type. From there it goes on to a field speaking of tumor extensions, so where does the tumor invade, or what areas does it involve? So you have, for instance, parietal pleura with or without involvement of the ipsilateral visceral pleura, confluent visceral pleural invasion, invasion of diaphragm and lung, and so on and so forth. One area that causes some confusion sometimes is the endothoracic fascia, which really is more of a gross finding or an intraoperative finding. This is a connective tissue layer external to the extrapleural fat, and oftentimes can form a good plane of dissection for the surgeons. It can be very difficult to delineate histologically. The appearances, in my experience, can be quite variable. Sometimes you can see connective tissue with some elastic fibers. Other times it's really not so well delineated. So whether or not the endothoracic fascia has been taken may require correlation with the surgeon and the intraoperative findings. Chest wall invasion sometimes is difficult to assess, but in extrapleural pneumonectomies and sometimes even in pleurectomy specimens, you may get chest wall elements, which are defined as ribs, intercostal muscles, and supporting connective tissues. The CAP protocol does make specific note that it does not consider extrapleural fat adjacent to the parietal pleura to constitute chest wall invasion. Oftentimes it's kind of moot, but very often we may see invasion of the extrapleural fat without invasion either of bone or muscle. Moving on to margins and treatment effects. Margin assessment for large mesothelioma resection specimens, as you may well imagine, may be quite difficult. For pleurectomy specimens or extrapleural pneumonectomies, really the entire surface is potentially a margin, and we can really only sample a very small proportion of that, but I guess we try our best. Treatment effects, likewise, can be very difficult. Oftentimes it really doesn't seem like the tumor has been affected at all by a neoadjuvant treatment. So you can see that the categories here are really quite broad, greater than 50% residual viable tumor or less than 50%. But really there's no formal standardized scheme for evaluating treatment effects. Moving on to staging of mesotheliomas, there is a TNM staging classification. The TNM descriptors for multiple primary tumors, recurrent tumors, and post-treatment tumors do apply, although the M suffix for multiple tumors generally isn't used for mesothelioma since these tumors are mostly diffuse. The Y prefix is one that is commonly used because these patients often will undergo neoadjuvant chemoradiation prior to resection. And I would just note that for the centers that prefer using a different staging system, that the CAP protocol doesn't necessarily preclude use of those other systems as well. So for T stage, T1 to T4, with mesotheliomas, T1 basically is the tumor confined to parietal pleura without visceral pleural involvement for T1A or with for T1B. T2, for most purposes, refers to involvement into the diaphragm or underlying lung parenchyma. T3 tumors are locally advanced but potentially resectable tumors that invade one or more adjacent structures, including the chest wall and endothoracic fascia and mediastinal fat. Invasion into but not through the pericardium is also considered T3. T4 is listed as locally advanced, technically unresectable tumors. If it's unresectable, then you may ask, why are we receiving it? Because it's been resected. Well, oftentimes, clinically, it may not appear to be unresectable, but when we get the specimens, we see, for instance, diffuse or multifocal extension into the chest wall. We may on occasion see extension through the diaphragm or through to the internal surface of the pericardium, or we may see invasion of other structures, which would constitute T4. Nodal staging is very similar to lung cancer staging, with N1 being ipsilateral bronchopulmonary hilar nodes, N2 being ipsilateral mediastinal nodes, but also including internal mammary and peridiaphragmatic nodes, and N3 largely being contralateral lymph nodes and supraclavicular nodes. And then there's also some space to count the number of lymph nodes examined and involved. And as Dr. Churg has mentioned, distant metastases of mesothelioma may occur on occasion. Finally, for the mesothelioma protocol, there is space for additional pathologic findings, such as asbestos bodies or pleural plaques, pulmonary interstitial fibrosis that may be indicative of asbestosis. And then there's space for ancillary studies like IHC or FISH, and for clinical history. Okay, moving on to the Thymoma and Thymic carcinoma protocols. We'll leave questions, I guess, for the end. Current version was also posted in February of 2011. Thymic epithelial neoplasms are really quite rare. They constitute less than 1% of all adult cancers, with an incidence rate of between 1 and 5 per million population per year. Peak incidence in the 6th and 7th decades, and these are fairly rare tumors in children or younger individuals. No gender predilection. Clinically, they may be associated with myasthenia gravis, but not always. And the etiologic factors are largely unknown. The CAP Thymoma and Thymic carcinoma protocol begins with specimen information, so the specimen type, generally speaking, thymus resection or thymus plus something else. Oftentimes, the tumor may be either adherent to or invading adjacent structures, which may include the lung, the pericardium, maybe some of the large vessels in the vicinity as well. And as with other CAP protocol types, there's entries for specimen integrity, weight in this case, and tumor size. The histologic type of thymic epithelial neoplasm, this is obviously an area that's been quite controversial over the past maybe 4 or 5 decades. That seems to have settled down a little bit, although it seems like it may be continuing in some quarters. Histologic type for the CAP protocol basically follows the WHO classification and lists type A, AB, B1, B2, and B3 thymomas. In the WHO classification, there are a whole host of other minor subtypes that are listed, which are just sort of in this catch-all category of other. So running quickly through the different histologic subtypes, type A thymoma historically has also been known as medullary type or spindle cell type. This is characterized by spindled or ovoid epithelial tumor cells, which are generally fairly bland in their appearance, as you can see kind of in the top panel here. These tumors typically lack lymphocytes that are positive for either TDT or CD1A. While the majority of these tumors exhibit at least some areas of spindled or ovoid epithelial cells, they may also demonstrate other minor histologic patterns. So, for example, rosette-like structures, as we see in the bottom panel here, sometimes gland-like spaces, microcystic patterns. These can all fall under the moniker of type A thymoma. These are tumors that are generally encapsulated and generally exhibit low-grade behavior. Type AB thymoma, as the name would suggest, has a mixture of type A and type B patterns. Type A here in the upper panel, type B in the lower panel. And these components may form either discrete nodules or they may be quite intimately intermixed. These tumors are also generally fairly low grade. So moving on to the B-type thymomas. Type B thymomas are composed of an admixture of neoplastic epithelial cells and varying degrees of infiltrating lymphocytes, with B1 thymomas being most lymphocyte predominant and B3 having the fewest lymphocytes. So B1 thymomas, also known as predominantly cortical or predominantly lymphocytic type, these tumors have a very lymphoid-rich background. You can see it's really quite blue at low power. At higher magnification, again, you see predominantly lymphocytes, but you see occasional larger cells with fairly open-looking chromatin, occasional small nucleoli. These are the epithelial cells that are scattered throughout this lymphocyte-rich background. I would note that these lymphocytes typically are positive for both TDT and CD1A. Some minor features of these tumors include so-called medullary islands, which are these paler staining areas that can be seen at low power, and these tend to have fewer of the TDT or CD1A positive lymphocytes. I would also note in passing that type B thymomas may also have Hassel's corpuscles. Once in a while we may get consultations for thymic tumors that otherwise look like B1 but have prominent Hassel's corpuscles, and the question is this just thymic hyperplasia or is it thymoma? So B1 and other type B thymomas can have Hassel's corpuscles, so the presence of these corpuscles does not rule out neoplasm. B2 thymomas, also known as cortical or predominantly mixed type, have more prominent epithelial component than B1 and less lymphocytes. So in this case, you can see that while there are still numerous lymphocytes, the epithelial cells are more prominent and are starting to form aggregates of 2 or 3 or 4 or even more epithelial cells together. I tend to think of type B2 as having something like a 50-50 admixture of lymphocytes and epithelial cells. And these tend to be more aggressive than the types that we've talked about previously. Compare that with type B3 thymoma, and you have fewer lymphocytes still, and rather you have a predominance of epithelial cells. You may start to see a little bit more nuclear atypia in these B3 tumors to the degree that the features sometimes may actually overlap with thymic carcinoma. B3 tumors generally are more aggressive than either B1 or B2, but that's a general rule. It doesn't always hold. Moving on to thymic carcinomas, there's a whole list of different types of thymic carcinomas. Probably the most common ones would be squamous cell carcinoma and the neuroendocrine type carcinomas, be it typical or atypical carcinoids, occasional large cell or small cell carcinomas as well, and then a number of other minor subsets. These are tumors that are typically cytologically malignant, so if you took the tumor out of the mediastinum and put it in any other body site, it would be considered malignant. The infiltrating lymphocytes typically lack expression of TDT and CD1A, and the epithelial cells are often positive for CD5 and CD117. These tumors are often grossly invasive. So this is just one example of a poorly differentiated thymic carcinoma. There's additional tumor information that is included in this protocol: tumor extension into adjacent structures such as lung, pleura, pericardium, or diaphragm, margins and treatment effect, and lymphovascular invasion. I would note that margin assessment can often be challenging for a number of reasons, not the least of which being that the anatomic relationships that may be present in situ may no longer be apparent once the tumor and the thymus have been removed from the body. Other things like capsular retraction, sometimes anterior or pleural surfaces aren't really truly resection margins. And oftentimes it may be helpful to go back to the surgeon to really try to confirm the orientation of the specimen. With margins, I'd also note that if there's a piece of lung or pericardium that's attached, that those margins should also be assessed. In terms of lymph nodes, there's a space for a number of lymph nodes examined and involved. I would note that nodal metastases are really quite uncommon for thymomas, but may be more frequent for thymic carcinomas. Okay, final segment of the protocol has to do with staging of thymomas and thymic carcinomas. For thymomas, probably the most widely used staging system is a modification of the Masaoka staging system that's listed here in the protocol. This only applies to thymomas. For thymic carcinomas, there's kind of a TNM staging classification that the CAP protocol uses, which we'll touch on briefly. This Masaoka stage basically breaks down the staging into stages 1 to 4, 1 being completely encapsulated tumor, 4 being widely disseminated with distal implants, whether in pleura or pericardium or in other body sites. So stage 1 tumors, according to the Masaoka-Koga staging system, there was a nice review published on this in the Journal of Thoracic Oncology back in 2011. These stage 1 tumors are completely encapsulated both grossly and microscopically. So here you see some normal thymus on the left side, encapsulated tumor on the right. You may on occasion see the tumor protruding into the capsule, but it does not extend through the full thickness of the capsule in stage 1 tumors. For stage 2, you get complete transmural or transcapsular invasion into the adjacent mediastinal fat, as is illustrated here. And stage 2 is broken down into stage 2A, which is only microscopic transcapsular invasion, and 2B, in which the transcapsular invasion is grossly identified, or if the tumor is grossly adherent to either the mediastinal pleura or pericardium, but there is no invasion of either of these structures histologically, that's considered stage 2B. This is an example of stage 2A with sort of microscopic transcapsular penetration into adjacent mediastinal fat. Stage 3 in this system refers to macroscopic invasion of neighboring organs, most commonly invasion into the pericardium, mediastinal pleura, lung. Vagus and phrenic nerve sometimes may be invaded, may be very difficult to identify these once it's out of the body, and also great vessels. Stage 4 is locally advanced intrathoracic disease with pleural or pericardial dissemination forming stage 4A, or distant metastases, including lymph node metastases, constituting stage 4B. For thymic carcinomas, strictly speaking, the Masaoka-Koga staging system generally isn't used. There is a TNM classification that's provided in the CAP protocol, but this is not one that's officially recognized by the AGCC and UICC. It looks quite familiar with T and M classifications, and you'll notice that the T classification in many respects is basically follows the Masaoka-Koga staging for thymoma, but metastases are taken out to a separate category, at least for distant metastases as well as lymph node metastases. Finally, in the CAP thymic protocol, there's space for additional findings, most commonly involutional changes in the surrounding thymus, but sometimes cortical hyperplasia, cystic changes, whether in the tumor or in the benign thymic tissue, and space for ancillary studies for those who may be interested in including that. I guess I would just take this opportunity to go over a few IHC markers that we tend to use here. TDT or CD1A for lymphocytes in the type B thymomas. Keratin and P63, just to confirm the epithelial cellularity. On rare occasion, we get core biopsies that end up being TDT positive lymphoma and keratin stains in that setting, just to confirm that there are epithelial cells present may be useful. And then CD5 and CD117 may be positive in a fair number of thymic carcinomas, tend to be negative within thymomas. I would just state that CD5 staining, especially, and CD117 as well, is not specific for thymic origin. Many other carcinomas and sometimes squamous cell carcinomas of the lung may actually stain for CD5, so it's by no means specific. But in the context of a primary mediastinal tumor, CD5 positivity may be useful for distinguishing between thymic carcinoma and thymoma. I'd just like to say thanks to Dr. Ming Chow for providing some of the slides for this talk as well. Okay, that's it for me. I think we can take questions.
Questions? Yeah, there are a few questions. The first one is tissue invasion. Is it for all malignant mesothelioma or only sarcomatoid as a criteria?
No, tissue invasion is by far the best criteria for malignancy in any kind of mesothelioma, epithelial or sarcomatous or mixed. If you see tissue invasion, you're sure they're mesothelial cells, then that's a malignant mesothelial proliferation.
Okay. And second question is, may we use elastic stain for delineating the endothoracic fascia?
Yeah, that's kind of variable. I mean, you can. It doesn't always show a very well developed elastic layer. It's really kind of hit and miss, and endothoracic fascia may be the most reliable way to know that that's been invaded is if you actually see invasion of skeletal muscle, chest wall skeletal muscle, because by that point certainly it's gone through the endothoracic fascia. But otherwise it may be very difficult to ascertain whether that's been invaded or not.
Okay. The second one, and the other one is, David, our thoracic surgeons are asking to classify thymoma on the biopsy. How important is that in terms of management?
Well, that's a good question. I mean, there are various clinical criteria for whether or not the patient may be getting neoadjuvant therapy before the resection. And I think it seems to vary from center to center. I think if it's a thymic carcinoma or sometimes even a B3 thymoma, they may take a slightly different approach. but I mean, oftentimes thymomas may show heterogeneity, and I mean, you may have a thymoma that looks like a B1 on a needle core biopsy, but then when you get the resection, there's lots of other areas that are sort of either B2 or B3. Similarly, type AB thymomas, depending on where you sample, it may end up being called something else. So, I mean, where the type seems quite obvious on a needle core biopsy, I will often provide the WHO type on the core biopsy, just in case that is useful information, with the caveat that the final typing may change when we've had the chance to review the resected specimen.
Okay. And another question is, do we use invasive growth with desmoplasia as a criterion for thymic carcinoma when there's no overt cytological malignant features?
So do we use invasive growth with desmoplasia?
Yes.
As a criterion? That's a good question. I'm not sure how reliable that criterion is if there's no cytologic atypia. I mean, on occasion, type B thymomas can, often they can invade. I don't know how often they're associated with stromal desmoplasia, but recognizing that oftentimes there are sort of gray zones. I mean, in that sort of situation, I would be seeing whether I can get some guidance from the CD5 and CD117 stains. If it's a type B looking thymoma, the absence of CD1A positive lymphocytes may tip me in favor of thymic carcinoma. But in general, if you have a tumor that otherwise looks like a B3 thymoma without much in the way of atypia, we tend to go more towards B3 than thymic carcinoma, but it can be a difficult call sometimes. I don't know if Dr. Churg has a different approach.
No, not really. My experience was that desmoplasia seems to be pretty uncommon with thymomas and even with thymic carcinomas. I think we judge much more by simple invasion than looking for desmoplasia.
Okay. Another question. In small intrathymic thymomas with tumoral capsular invasion, but no invasion through the thymic capsule, do you stage as T1 or T2?
So I would stage those as 1A if they're completely encapsulated and not invading through the capsule. It's only once they've penetrated through the full thickness of the capsule that would be considered stage 2.
Okay. Is there a role for vimentin in the distinction between epithelial mesothelioma and carcinoma?
No, that's ancient stuff, some of which, unfortunately, I actually published. Vimentin turns out to stain too many things, and I don't think it actually, at this point, is really of any use. The only use I can see to vimentin is it just tells you that antigenicity has been preserved.
Any comment on papillary mesothelioma?
Well, that's a whole can of worms, and that's an important question, actually. We're really talking about two entities. There are ordinary epithelial mesotheliomas that may have a papillary component. And then there's the completely separate entity called well-differentiated papillary mesothelioma. Well-differentiated papillary mesothelioma usually is an incidental finding in the peritoneal cavity in women. It looks like small translucent nodules, and most of those are functionally benign tumors. Epithelial mesotheliomas with a papillary component are just epithelial mesotheliomas. To avoid confusion, I recommend not putting any kind of denoting comments with your ordinary mesothelioma. In other words, do not call it a papillary epithelial mesothelioma because there's the potential for confusion with well-differentiated papillary mesothelioma. Just call your epithelial mesotheliomas epithelial, even if they have a papillary component.
Okay. And last question is, what is your experience with localized mesothelioma? And do they relate also to asbestos exposure?
Localized malignant mesotheliomas are tumors that microscopically look exactly like diffuse malignant mesotheliomas, but by definition are sharply circumscribed nodules with no gross or microscopic evidence of diffuse pleural spread. Those tumors are different, and you need to tell surgeons and oncologists that they are different because those should be treated by wide local excision. In other words, like a localized sarcoma on the pleural surface. And if you do that, you get about a 50% long-term survival. So it's important when you have such a tumor to make a comment to the effect that these tumors require local resection. The relationship to asbestos, probably there is none. The literature is thin. Many of these tumors occur in women who generally don't have asbestos exposure. My belief is that there's no documented association with asbestos exposure.
Okay. From Grand River, do you use IHC to differentiate benign from malignant mesothelial proliferation, even with knowing that they are not diagnostic peritoneal localized papillary mesothelioma, low grade?
Okay. That's one of those questions that we could talk about for half an hour. I'm of the belief that immunohistochemistry, as a rule, is no use separating benign from malignant mesothelial proliferations in an individual case. Statistically, you can make some of them work, but that's only in series of cases. There's just too much overlap for any individual case to make it reliable.
There's actually a second part to this question as well, if it helps.
Okay.
Do you make this diagnosis, and what is the prognosis?
Okay, go back to the first part because I think I missed the second part of the question.
Sure. So, do you use IHC to differentiate benign from malignant mesothelial proliferation, even with knowing that they are not diagnostic peritoneal localized papillary mesothelioma, low grade? Do you make this diagnosis, and what is the prognosis?
Okay, I'm not entirely sure I follow the question. For well-differentiated papillary mesothelioma, as a rule, they simply are benign. They may stay around, but they're functionally benign. For any diffuse malignant mesothelioma, those are all malignant, and it doesn't matter whether they have a papillary component. But to come back to the beginning of the question, I do not use immunohistochemistry for making the distinction between benign and malignant. Now, there is one exception. We have a paper in press showing that BAP1 loss is a marker of malignancy, and that may prove to be something that actually works because there are some molecular reasons why BAP1 should work. But for things like EMA, P53, IMP3, GLUT1, in my opinion, those are no use in an individual case.
Okay. So there's another question as well. Dr. Churg, can you make a diagnosis of desmoplastic mesothelioma with no stromal invasion and no nodules, no pleomorphism, no necrosis, etc., if P16 FISH is positive?
Well, the answer is yes, probably. But let's step back a second and ask the question. If you have something that's a thickened pleura, falsicellular, but there's no evidence of invasion, no necrosis, no nodules, why do you think it is a mesothelioma to start with? Now, if the clinical scenario is that the radiologist says there's nodular pleural thickening, or the thoracoscopist tells you, I've looked at the pleura and there are multiple tumor nodules, then I suppose in that circumstance, yes, you could use P16 FISH, and if it's deleted, yes, it's malignant. But that's a bit of an unusual circumstance. Most of the time with desmoplastic mesotheliomas, there's something else that gives you the hint that it's malignant. As you may gather, I depend very much on clinical scenario. If there's no evidence from radiology and there's no evidence from the thoracoscopist that there's tumor, then I'm going to really step back and be extremely cautious. Occasionally, you do see a mesothelioma that's so thin it doesn't show up, either visually or radiologically, but that's pretty unusual.
Okay. And there's a comment, the last comment. Radiologist says suspicious for mesothelioma. I'm not sure if that's... and
well,
another question that just came through, actually. Any role of Desmond stain of malignant versus benign mesothelial proliferation?
Sorry, what role for what stain?
For Desmond stain.
Oh, okay. Yeah, Desmond's another of those things that, in my opinion, is absolutely no value whatsoever. It has been claimed that Desmond is a marker of benign proliferations, but I can show you perfectly happy, clearly malignant mesotheliomas that are Desmond positive. So no, that's another marker I simply don't use.
Okay. I'm not sure if there are any more questions coming in, but I don't see any other questions for now.
Okay. Can you hear me, Hyatt?
Yes, I can hear you. Yeah.
So I'll just make a few closing remarks now. On behalf of Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists, I really want to thank Dr. Andy Churg and David Hwang for a truly comprehensive, informative, and a very clear presentation this afternoon. This is the second session of our 2015 series of CAP checklist presentations, and we would welcome comments and suggestions of ways to ensure that these sessions are informative and relevant to your practice. Please include your feedback and suggestions as part of your online completed evaluations. Once this WebEx recording of the presentation becomes available, it will be made available through a wide distribution links posted by Cancer Care Ontario, CPAC, and the Canadian Association of Pathologists. Access to the recording will be available for your review at your convenience and is not restricted. As a reminder, both the live and recorded presentations are eligible for CME credits. Please see the session notice for more information. And once again, please remember that the CME certificates will be issued for only 1 month after the presentation date. The sessions will remain available electronically for an undetermined period of time, but the CME certificates only for 1 month. Please refer to the session notice for more information. And please put a note in your calendar. Our next session is going to be on February the 11th. And it'll be given by Dr. Martin Bullock, and it's on the new thyroid electronic cancer checklist. So look forward to seeing you at that meeting. Thank you for your attendance.
Thank you.
Bye now.
Thank you.
Bye. Thank you.